All right, good evening, everyone. Thank you so much for joining us for this virtual community chat all about pelvic health. It's one of my favorite topics to be talking to you about, so I am excited to be able to be a part of this with you tonight. My name is Jenny Gablesberg, and I am a pelvic health physical therapist here in Torrance. And we tonight are going to be joined by three of our local physician experts on all sorts of pelvic health issues. We have Dr. Reza Askari, Dr. Shelby Morrisroe, and Dr. Erin Mellano joining us tonight. So we want to let everyone know this is going to be an hour-long presentation, but we are going to be saving a few minutes at the end for your questions. So at the bottom of your screen, you're going to see a Q&A button. And what you can do anytime during the talk, anytime you have questions kind of pop into your head, go ahead and put them right into the Q&A box. They will show up on our end. And we will hold those until the very end after all three physicians have done their presentations, and then we will be asking those. We are not opening up for any live questions to be happening tonight. So if you have any questions that you would like to get considered to be answered tonight, go ahead and throw them in that box for us. So before I introduce our speakers, I want to give you just a little info about my role with this particular group. Tonight, I am your moderator, so I will be introducing the speakers, telling you a bit about them before they do their slideshow. But my real hat is as a pelvic health physical therapist. I own Women's Advantage Men's Optimal Health Physical Therapy. We have a location in Torrance and one in Long Beach. And I have been lucky enough to work with all three of these physicians for many years. We've been providing pelvic health physical therapy for the last 20 years, and we are contracted with Providence Hospital to be able to provide care to any of their patients who have pelvic health challenges. So I am super excited to be part of this tonight. I also want to let everyone know it is currently open enrollment period for Providence. And so if you have any interest in learning more about their options, you can go to chooseprovidence.org to have all of your questions answered. And our lovely host, Katie from Providence, is going to put that right in the chat for easy access for you. You can click onto that and open it in another link, so you have that available to look at after the presentation is over. Lastly, I just want our attendees to know that the information provided tonight during this program is for educational purposes only. If you have any personal questions, concerns, challenges, you should always consult your healthcare provider to be able to discuss your personal medical condition. So now it is my pleasure to introduce our first speaker of the evening, Dr. Shelby Morrisroe. Dr. Morrisroe is a board-certified urologist with a fellowship certification in female pelvic floor medicine and reconstructive surgery. She bridges the gap between gynecologic and urologic medicine and manages all female urologic issues, including incontinence, pelvic organ prolapse, prior failed vaginal reconstructions, and complications resulting from the use of vaginal mesh, recurrent UTIs, and vaginal atrophy. She has now been in practice in the South Bay for 10 years. So please give your attention to Dr. Morrisroe.
Hi, everybody. Happy to be here and share with you some information on stress urinary incontinence 2021, some updates and some new options that maybe some of you haven't heard about before. Let's see. So again, I'm Shelby Morrisroe. I work at Genesis Urology here in Torrance, treating everyone in the South Bay, from Long Beach to El Segundo or outside. And again, talking about stress urinary incontinence today. If you don't know, the basic definition of urinary incontinence is an involuntary loss of bladder control that causes the release of urine. There are four basic types of incontinence. We're going to be mostly focusing on one type, stress incontinence today, but just to briefly mention, urgency incontinence is the other common type that people think about when they've got to rush to the bathroom, don't always make it, trying to get there, turn the water on, rush to get home. That's called urgency incontinence. There's another form called functional incontinence, which is mostly related to poor mobility issues, functional impairment that makes it hard to get to a bathroom in time, and overflow incontinence, which is mostly related to an inability to empty the bladder, urinary retention causing leakage of urine with movement or bending because your bladder is so full. And again, we're going to focus today on what's in red, stress urinary incontinence. So stress urinary incontinence is involuntary, specifically an involuntary loss of urine that occurs with physical exertion of some kind. Coughing, laughing, lifting, jumping, trampoline, exercise, exertional movements that push urine out. It's actually quite common. It's the most common type of urinary incontinence. 1 out of 3 women in general over age 45 have some degree of stress urinary incontinence. So you can see it's quite prevalent. There is often a mixture of different types of incontinence, which is always really important for us as physicians to figure out what our patients suffer from exactly, because sometimes people have never really thought about the different types. About half of people with incontinence primarily and only complain of exertional leakage, but the other half have either a mixture of exertional related leakage and urge leakage, or just urge leakage itself. So sometimes patients come to me and they're just really, they know they're leaking urine, but they're not sure when it's happening. So it's our job to kind of help figure that out. And it's very important because the treatment options are actually quite different. So goals for today for me, just to understand what stress urinary incontinence is, and to kind of briefly review some causes, reasons why women get this, and to learn about the workup of it, and most importantly, talk about the different treatment options. There are some invasive and non-invasive treatment options. We're going to go over all of them a little bit, which generally include physical therapy, exercises, other conservative measures, potentially some medications, as well as laser therapy, minimally invasive injection therapy, as well as classic surgery. Just very briefly, evaluation of the woman with incontinence. It's all about history, and quality of life questions. Very important, again, to ferret out, is it mostly exertional related leakage, urge related leakage, a different reason for incontinence, or a mixture, and to really focus on what the quality of life impairment is. Generally speaking, it's pretty rare that we recommend treatment of incontinence for someone if they really have no bother. It's the bother and quality of life impact that really drives how aggressive we are with treatment, not so much the actual having of the leakage. So we really focus on that in the office. On exam, we always check a urine. We want to make sure there's no concomitant issues such as infection or blood in the urine that could indicate something more serious. We do an exam to check for other issues that could go along with incontinence, like vaginal prolapse, which is a bulge of the vaginal tissues, which could include the bladder or rectum, which can contribute to this problem. We evaluate with some coughing. We try to elicit the leakage. And a woman who has pure stress exertional leakage with really no other issues does not necessarily need any advanced testing. We sometimes do tests called cystoscopy or urodynamic testing. Some of you may have heard of that before. They're basically the ways that we look at the function and anatomy of the bladder. But a woman with pretty straightforward exertional leakage does not generally require these advanced testing. So you can get evaluated and treated for exertional leakage without, more advanced testing. And sometimes that keeps people away from coming in. They hear about these tests. So I just want to make it clear that pretty straightforward cases really don't need too much workup. Why do women get stress urinary incontinence? 2 main categories. The most common is basically a weakness of the pelvic floor muscles, structures, ligaments around the urethra, kind of a hypermobility or movement related leakage of the urethra. This is due to anatomic defects in the support structure around the urethra. This can be partially genetic. It can be from weak connective tissue. It can be just weak pelvic floor muscles and ligaments. It can be brought on by pregnancy changes, obesity, chronic coughing. A smaller subset of women with exertional-based leakage, though, have an actual compromise of the sphincteric mechanism of the urethra. We call this intrinsic sphincter deficiency. It's a big term, but it really just means the vasculature of the urethra has been affected, the nerves have been affected, radiation, prior pelvic surgery, aging can lead to this. This is tricky and important thing for us as physicians to try to decide if a patient has this, because this type of leakage can be a little different to treat. And even though it's motion related, it can be kind of like an open lead pipe type urethra that doesn't always respond to classic surgery. So again, the most common type of exertional leakage is hypermobile urethra, which is in some form a weakness of the pelvic floors and ligaments. Just another quick note on the more kind of open affected urethra called intrinsic sphincter deficiency. This is leakage that occurs with very little activity. You basically move slightly and urine comes out, any slight motion. Again, it's more common in the elderly. Postmenopausal tissue can lead to this, along with other aggressive things such as a prior history of radiation or pelvic surgeries. And this can be a little more difficult to work up than the straightforward stress incontinence. Big important takeaway point from today is that incontinence is not what we consider a normal part of aging. It's more common as we age, but it's not normal. So we want to encourage everyone to talk to their doctor about this and see what treatment options are available. A lot of patients come to me and say, oh, I just assume this is normal because I'm getting older. Again, we don't consider it normal, just more common, and lots of treatment options are available. Management of exertional leakage. The first stuff we always talk about is conservative therapy. We encourage every one of our patients to consider basic exercise work, such as Kegels, most people have heard of, pelvic floor therapy, potentially biofeedback. Weight loss for obesity can contribute to leakage. There are Pessaries, which are little round plastic devices you can place vaginally if there's any vaginal prolapse along with the leakage. Some people insert things like tampons in the vagina to put pressure on the urethra, which can help with leakage. So these are all kind of in the realm of conservative therapies that are non-medicine, non-surgical based. We'll go through some of those in a little bit more detail. Medication, exertional leakage is not typically treated with classic medication like overactive bladder often is. Vaginal estrogen in some women can help exertional leakage. So that's always something we kind of talk about in the postmenopausal woman with exertional leakage as an option that may help. There is also some off-label oral medications, such as duloxetine or imipramine, that potentially can help. We don't use them very often. They do have a higher risk of side effects and aren't as effective as other medications for overactive bladder, but they do exist. And the more common treatment options after conservative therapy tend to be procedural for exertional leakage. There is a fractional CO2 laser. There's a couple different kinds that we can use that help about 50% of the time for mild exertional leakage. We'll talk a little bit about that. There's the classic surgery, which is considered the gold standard or best successful treatment for exertional leakage. We'll talk a little bit more about that as well. And the kind of newer treatments are advanced urethral bulking agent injections. It's a mouthful, but it really just means we're injecting a filler material into the urethra to plump it up. And we will also talk more about that in some detail. Behavioral modification has to do with not over drinking, time voiding, making sure you're not letting your bladder get too full by waiting too long, and then you cough or jump or run and you have a big accident. Sometimes if you just empty the tank more often, you won't have those big accidents with exertion. Pelvic floor exercises, referrals to physical therapy. You know, we always recommend starting with if that's an option for you. I liken doing pelvic floor therapy with a physical therapist, much like going to the gym by yourself versus hiring a personal trainer. You're always going to get better results and more aggressive regimen if you work with a personal trainer than try to do exercises by yourself. However, there are great books out there and online self-studies, so it is something that you can work on by yourself as well. Biofeedback is kind of a form of what they can teach you in physical therapy. It helps you learn proper technique for the pelvic floor exercises, gives you a lot of feedback. And it's a time commitment, but we encourage people to pursue the physical therapy and biofeedback. But you will see changes in the muscle function sometimes before the clinical improvement. So it's something we want you to stick with for a few months before deciding if it's helping or not. Functional electrical stimulation is another form, kind of like biofeedback. It's not always as easily offered, but it has to do with some passive electrical devices that can help with pelvic floor exercises. It's something that if you're working with a pelvic floor therapist, they can discuss with you as well. So again, these are non-surgical, non-medication options that can potentially help with your exertional leakage. Weight loss, important to talk about weight loss. Obesity is not good for anything, puts pressure on the bladder, and there's definitely a dose response effect of weight gain on incontinence. So a lot of studies out there have shown that weight loss in the obese patient can really help with their exertional leakage, as well as other health benefits, of course. Management devices, again, non-medicine, non-surgery. I briefly mentioned a Pessary, like what's down here on this lower left screen, is just a plastic ring you can insert in the vagina. It's mostly used for prolapse to lift things up, but they can come with a little knob that presses against the urethra to help with leakage. Some women apply tampons before they go on a run. That can help with exertional leakage. And Poise actually makes an insertable over-the-counter device called Impressa. You can get at your local CVS, which has a similar mechanism Again, it's a nice option. It's non-surgical, non-medicine. It's just a temporizing agent, but a lot of women do find them helpful. Moving on to some of the procedural options, the fractional CO2 laser, the one we use in our office called the Mona Lisa Touch. It's an off-label use for exertional leakage. It works about 50% of the time to help with mild stress incontinence. It's about a 5-minute procedure in the office. It's basically painless with a little numbing cream applied externally. And it consists of 3 treatments 6 weeks apart and an annual maintenance treatment to do. So there is kind of an ongoing treatment with it. But it is a nice option if you're trying to avoid surgery or anything more invasive out of the office. What is it? It's just a laser probe that goes in the vagina. It creates a few small injuries along the vaginal tissue to trigger a healing response. That healing response helps bring in collagen, hyaluronic acid, growth factors to improve the vaginal tissue health and strength. And that can subsequently lead to better support and less leakage. This is just a before and after picture of how the vaginal tissue can look 3 months after doing a vaginal laser treatment. It becomes a little thicker, healthier, better moisturized, better pH, and that again can potentially lead to improved overactive bladder or incontinence symptoms. That's a nice option in the office, no surgery. Surgical options, again, kind of considered the gold standard repair for surgery, typically nowadays are called mid-urethral slings. You can do them a couple different ways. There's also a way to perform a sling insertion with your own body tissue. It's called an autologous fascial sling. It's just a different kind of technique. And then we're also, again, going to talk about that urethral bulking agent injection. The most recent injection that we use is called Bulkamid. We'll go through that just the next few minutes. So the mid-urethral sling, we're just going to talk a few minutes about that. It's the classic sling surgery, the gold standard. The goal is to re-support the urethra or provide a back support underneath it. So when you bear down or cough or jump or run, the urethra has something to close against and you don't leak urine. There's a couple different angles that can be placed, some slightly different techniques, but in general, the surgery takes about 40 to 45 minutes. It's outpatient with a 1-month recovery. Not that someone will usually be in pain for 1 month. We just restrict heavy or full activity for 1 month to let things heal up. And there's about an 89 up to 95% long-term success from the surgery. So it's highly successful. There is actually a very low complication rate with this type of surgery alone, but they can be potentially serious. And complication rates with the surgery is what sometimes motivates people to do some of our less invasive treatment options. Again, it is considered the gold standard treatment. It has the highest success rate and generally speaking, an acceptably low rate of complications. This is just a visual picture. Sometimes people don't know what I'm talking about when I say sling, just to kind of show them the arrow pointing to this, what looks like a piece of tape kind of slung around the urethra at the level of the mid-urethra in front of the bladder neck. This pink structure here is the bladder. This is the urethra, and the tape kind of slings around it. This is placed surgically. This is a side view angle of a similar device. In blue here is the sling slung basically around the urethra. That's just kind of a visual picture for people who aren't quite sure what we say when we talk about sling. This is a transobturator sling position. It's just a little bit differently placed, but you can see the white tape around here kind of slung around the urethra a little more laterally. The autologous fascial sling is really the same concept. It just does not use any permanent mesh. You would ask why wouldn't everyone have this type of sling then when they have incontinence if it doesn't use any permanent material? And the answer is it's just a bigger surgery. It has a few higher risk of other types of complications with a bigger incision and a little bit longer recovery, but it is always an option for a woman who prefers to have the gold standard type of surgery, but without any foreign material or mesh. We do offer this. Again, it just is a little bit larger of a surgery. You can, in the picture here, I'm just showing you in the lower abdomen, the area of the woman's rectus fascia, which we remove and use as the sling material. This is just a strong connective tissue layering that goes over the abdomen that we remove and use as our sling material. Complications of slings. This is most women's concern about going forward with this type of surgery. It is still the most commonly performed surgical treatment for exertional leakage. The FDA does consider risk of the surgery to be an acceptably low risk. Lifetime serious risks from these surgeries are only about 4%, but they can include new onset urgency or overactive bladder, chronic vaginal pain, scarring, obstructive voiding, bleeding, groin pain. Sounds like a lot of things, but again, these are all very rare. 4 to 5% lifetime chance of any kind of significant complication. Most important, if you have one of these surgeries, it's just done with a doctor who, is very well qualified to manage any kind of potential complications. But overall, the risks of the surgery, these surgeries are very low compared to other surgical options with a very high success rate. The last thing I want to briefly talk about is kind of a newer alternative in the procedure world. This is a material called Bulkamid. It's an updated version of a technique of treatment for stress incontinence we've had for many decades, but just kind of the newest version. Works a little bit better, and we love it a lot. We've been doing it here in the United States for about 1 year, in Europe for 10. This is basically a filler or bulking agent, very analogous to when women get lip filler to plump up their lips. It's a gel-like material that we inject into the urethra to strengthen the urethral walls, to plump them up, to push them together. So when you cough or jump or run, you don't leak urine so much. Again, it's been here for about 1 year, in Europe for about 10. It takes about 15 minutes. There's no incision. It's just an injection into the soft tissue of the urethra. And what does it do? It adds volume to support the closing mechanism of the urethra. Again, kind of like lip filler, when women get their lips plumped up. The goal is to close off the urethral walls. So when you move and bend and jump, urine doesn't just kind of fall out. You can see on the picture below the before, during, and after of the injection. Down here on the left, you can see the wide open bladder neck where a woman would cough and urine might come through the tunnel of the urethra. Right here's the needle being injected into the mid-urethra to plump up the walls. And here on the right is the after appearance. Once we've injected the filler throughout the walls of the urethra is plumped up. The opening has kind of narrowed in a soft gel-like way and leads to less incontinence of urine with activity. What is it? It's a polyacrylamide hydrogel. It's a big word. It's actually 97% water, only 2.5% of this material called polyacrylamide. It's basically just a permanent gel, a soft gel that we inject, and it's relatively permanent. It can last as little as a few months, up to 7 or 8 years. It's got great long-term success in Europe, where it's been for about 10 years. We've done studies here in the United States that show about 75% of women after 1 year were either completely dry or very dry and happy with the result. And in Europe, where this has been around much longer, people have been dry up to 7, 8 years. So it's kind of a great new long-term option for stress incontinence. This is just a picture of kind of a diagram of what these gel inserts might look like. Here's your bladder, here's the urethra, and it kind of sits right between the two. This is another picture, kind of the same thing, just showing the needle, injecting the gel-like insert on one side, injecting on the other side, and you can see how the urethra gets closed off. That's the basic mechanism of how it works. Same picture here. This is before injection, kind of open, midway through injection with partial closure of the bladder neck, and after the final injections, closed off. Here's a quick video I'm just going to show you so you can see what I'm talking about. That's the open urethra and a needle going in, injecting the filler material, kind of plumping up the urethral walls. And you can see the urethral wall here expanding like a balloon. We're going to inject on the other side and inject the same material contralaterally to the first injection, plumping up that side of the wall. And you can already see that opening in the middle being closed off by these gel inserts. And we usually do about 4 injections all the way around the urethra to plump up the wall, to close off that opening in a soft gel-like manner. So it's not a hard structure. You can still pee through it. But when you bear down or jump, urine usually does not come out. That is the goal, to still allow normal urination, but not spillage of urine with exertion. So that's the final appearance after 4 gel inserts have been injected. You can see that opening is much more narrow than it was at the start of the video. Advantages of this injection: it's very low risk. There's no use of mesh. There's no incision. It can actually be done under local, meaning no general anesthesia. It can be done under IV sedation, which most people prefer, but it's not necessarily necessary. There's minimal to no recovery. You can go back to full activity the next day, and it has about a 75 to 80% overall success rate and is pretty durable. So in my opinion, the best thing about this injection is if for some reason it's not successful for you, you can immediately go on to surgery. Having this injection does not preclude moving on to more advanced treatment options such as surgery. So nowadays, a lot of women are wanting to do this type of injection first prior to moving on to a more permanent surgery. And thank you for listening. And I will take any questions at the end of the talk about this or other treatments.
Thank you, Shelby, for sharing that with us. I think your mantra and my mantra of common and normal are not the same thing is probably what we say 14 times a day. So I think one of the big take-home messages from that I hope you all got was that if someone, yourself or someone you know is suffering from urine leakage, that there are treatment options for that, and to make sure to talk to your physicians about that. So it is my pleasure to introduce our second speaker of the night, Dr. Erin Mellano. Dr. Mellano is a UCLA health physician, board certified in obstetrics and gynecology and urogynecology. She has a passion for women's health, specifically pelvic floor disorders and bladder dysfunction. She completed her residency in OB-GYN at UCLA, and during that time had the opportunity to work with a team of physicians treating complex pelvic floor disorders and fistulas in Uganda. This inspired her to pursue a fellowship at UCLA in female pelvic medicine and reconstructive surgery, also called urogynecology. Her primary interests include urinary incontinence, pelvic organ prolapse, overactive bladder, fibroids, pelvic pain, minimally invasive surgery, fistulas, and menopausal care. Dr. Mellano lives in the South Bay and practices in Torrance. She is a UCLA health physician with privileges both at Providence and Torrance Memorial. And in her free time, she enjoys running, hiking, and chasing after children. Welcome, Dr. Mellano.
Thank you, Jen. I'm going to move this over. Sorry, give me 1 second to switch it over. All right, we should be good now. Okay, thank you, everybody. Thank you for allowing me to have the opportunity to talk about pelvic organ prolapse, which couples nicely with Dr. Morrisroe's talk about urinary incontinence, because these are all pelvic floor disorders of different types. I think that urinary incontinence is probably discussed a little bit more often. And so I think that pelvic organ prolapse is the one that maybe people are a little bit more hesitant to talk about. So I want to sort of give a good examples of what pelvic organ prolapse is, talk a little bit about symptoms that people experience, talk about how we diagnose it, and then talk about some of the treatment options that exist. So just in general, it's a herniation of the pelvic organs to or beyond the vaginal walls, which basically just translates into it's like a hernia, almost like an abdominal wall hernia that you sometimes hear more commonly about, but of the pelvic floor. To show you sort of an anatomy picture to get a sense of what it is, because I think sometimes a picture is a lot easier to understand necessarily than just talking about it in words. In normal anatomy, your bladder would be right here in front. If this is the front of a person and the back of the person, this is your bladder. This is the urethra where the urine comes out. Right behind that is the vagina. And if you have a uterus in place, then at the top is the cervix and uterus. And then behind that is the rectum. So prolapse can occur in women with uteruses or without a uterus. And in this situation, it doesn't really matter which wall is coming down. Any of them can, but we used to define it specifically based on the wall. And in this case, this would be considered anterior prolapse because it's a weakness in the wall between the bladder and the vagina. And it would present itself as a bulge, but behind that bulge would be the bladder wall. Similarly, you can have uterine prolapse where the top of the vagina is coming down a little bit as well. And if the cervix is up there, it would be the cervix and uterus coming down. If there is no cervix, it would be more what we call vaginal vault prolapse, where it's the top of the vagina coming down, but there's no uterus there. You can also have a weakness in the wall that's between right here, between the rectum and the vagina. And that previously we called more often a rectocele. Now we sometimes just call it posterior vaginal wall prolapse. The real question is how common is this? And I think that we have a really hard time giving a good number on prevalence because it really depends on people coming into their physician and saying, hey, I am having some symptoms, and then being diagnosed with prolapse. We've tried to do it based on questionnaires. Sometimes it is difficult to know whether or not all of the women answering have prolapse, or it could be something else. And if some women do have prolapse, if we were to just look and take measurements, but because they're not symptomatic, they're not really endorsing it. Truly, the one that's most relevant are women that are having symptoms, because those are the women that we would like to treat. To get a sense of it, about 300,000 women undergo surgery in the United States annually for prolapse. This is a huge underestimate of the number of women that probably have prolapse, because there are lots of conservative treatment options. And so this is only looking at the surgical patients that had it. In addition, there's an 11 to 19% lifetime risk of needing some sort of surgery for a pelvic floor disorder, which again also underestimates the prevalence, because many women either don't go to their physician, think it's normal, are maybe too hesitant to talk about it, or undergo more conservative type treatments. So what are the symptoms? The most common symptom that women experience is going to be pressure in the pelvic floor. So pressure in the vagina, pressure on the rectum, but pressure that's sort of in the pelvic area. They may feel a heaviness or a weighted feeling. In addition, you can have symptoms involving either the bladder or the bowel. So in terms of urinary symptoms, some of the ones that Dr. Morrisroe discussed, things like urinary incontinence, urinary retention. So if that bladder comes down and it leads to like a little kinking of the urethra, some women actually have difficulty urinating. And so they'll endorse saying, listen, I really feel like I have to go, but I'm really not doing a good job emptying my bladder. And so I'll have to go again. Interestingly enough, because prolapse is somewhat gravity dependent, some women will say first thing in the morning, their symptoms are very minimal, but as the day goes on, they may experience more of the heaviness. And that's just because we're up and we're about. And so when we're up and about, you have more pressure pushing down. And so that's when it can present itself a little bit more. In terms of bowel symptoms, you can go either direction, either feeling like you're constipated and unable to evacuate. And some people will actually say, you know, there feels like there's a bulge and I almost feel like I have to push on the bulge in order to get the rest of my bowel movement out. So that's one symptom. Or it can go the opposite direction and women can say, well, listen, you know, I am having a little bit of leakage of stool because of the fact that there's a hernia there. So those symptoms can be there, and some women can feel embarrassed or uncomfortable with the prolapse, and so it can have some sexual dysfunction as well. In terms of risk factors, there's a multitude of risk factors. It doesn't mean that any one is going to be necessarily the sole risk factor. Oftentimes it's multifactorial. Pregnancy is certainly a risk factor, and type of vaginal delivery. So pregnancy is a risk factor, delivering vaginally, and then sometimes the delivery itself can be a risk factor, whether it's an operative delivery, if you've had to have forceps or a vacuum or something like that, or sometimes it's just the size of the baby. Age is a risk factor. So some women will have some symptoms, maybe premenopausal, but sometimes they can become more prevalent after menopause. And that also can relate a little bit to the estrogenization of the tissue. So if your hormones change, then sometimes some of the tissues can change and making prolapse a little bit more prevalent. Anything with a chronic strain or pressure. So whether that's lifting heavy things frequently, chronically kind of squatting and lifting without really protecting your pelvic floor. Chronic coughs are another big one. Heavy weightlifters. I've had patients who have never been pregnant once that are premenopausal, but who are big time weightlifters that have had problems with prolapse. Obesity is a risk factor as well, because it's just extra pressure on the pelvic floor. Some of it's just genetics and connective tissue itself. And then this has been long debated whether or not it really is a risk factor, but there's some data to suggest that hysterectomies may be a risk factor, especially if steps are not taken to try to prevent it from happening. So in terms of treatment, it's totally contingent on the symptoms and the degree of prolapse. So there's not any one particular treatment that is correct. It's what makes sense between the patient, the provider, the degree of prolapse, et cetera. It's a very shared decision-making process, determining whether or not to pursue treatment and the type of treatment to pursue. Expectant management is absolutely reasonable in many situations. If somebody was noted to have prolapse on exam and maybe it's mild and they have no symptoms, well, there's no real reason to undergo different treatments if the benefit doesn't really outweigh the cumbersome nature of the treatment or the risk of the treatment. Pelvic floor physical therapy, I think all of us today are going to be talking a little bit about that, but it's an excellent modality to help manage symptoms. Pessaries, which Dr. Morrisroe touched on for stress incontinence, are used many times as a conservative management treatment option for prolapse. And then there are surgeries and procedures. So we're going to talk about each one of these. In terms of expectant management, there's actually no data to do what the lady on the side of the screen is doing. Some people have tried doing things like inversion tables or standing on your head, and that's actually not been shown to improve the course of prolapse. But there are other things that can be done in terms of expectant management. The big thing we do as providers, if somebody is noted to have like moderate to maybe even severe prolapse, but they don't want anything done for it, we do monitor for new symptoms. And if it's severe, we really monitor to make sure that things like adequate urinary emptying is being done to make sure that there's no danger to any of the other organs. In and of itself, prolapse is not a dangerous condition. It's more of a nuisance unless it's really advanced and getting in the way of urination and other things. Things we can do, we can correct constipation, because if a big risk factor for it is chronically pushing down, well, if we can help correct bowel movements so that you're not having to push so much, that will be really helpful. Similarly, if somebody has really bad uncontrolled asthma, if you can help correct that, if you can help correct one of the instigating factors, it can be very, very helpful. We work on bladder training. So sometimes the only presenting symptom may not be the bulge, but it may be more of, listen, my symptoms are totally surrounding my bladder. And so we can work on doing some bladder training, bladder diet, et cetera, to help with the urinary symptoms. It may not be fixing the prolapse, but it will be helping the symptoms that are associated. Weight loss is another one that's very helpful. And I know Dr. Morrisroe touched on that as well, but it is very helpful for this. And to avoid repetitive heavy lifting and straining. So if there is a particular activity that's making you very vulnerable to having extra pressure on the pelvic floor, to avoid doing that will be helpful for you. Vaginal estrogen, like I said, many women, they may have a little prolapse, but it doesn't really present itself until after menopause. And that's just due to hormonal changes. Vaginal estrogen has been shown to help out a little bit with prolapse symptoms as well. Physical therapy. So I'm going to touch on this a little bit more. Basically, physical therapy is an excellent modality. It's been shown to really help improvement in symptom score, both in symptoms of the prolapse, but also in symptoms associated with the prolapse, like bladder symptoms and bowel symptoms. I also think it's an excellent modality for helping you to do the activities you want to be able to do without putting so much pressure on the pelvic floor. So maybe you didn't realize that while Pilates is really great for strengthening your core and everything else, if you're bearing down the whole time, then you're putting a lot of pressure. And so they can reteach some bad habits so that you're not putting so much pressure on the pelvic floor, so you can do your normal activities without having such a risk of having the prolapse progress or having a constant pressure there. So they've been shown to improve quality of life. They've been shown to improve prolapse-related urinary symptoms and defecation symptoms. And there's some data to suggest that it may improve the actual degree of how far down the prolapse is coming by maybe 1 to 2 centimeters, which is really relevant because typically speaking, women don't really notice their prolapse until it's coming to the vaginal opening. It may be coming down a little bit, but if it's within the vagina, you wouldn't notice that something's necessarily coming down. But when it comes to the opening, all of a sudden you say, oh, wow, there seems to be something that wasn't there before that is a little bit foreign to you. And that's when people notice it. So if you can get it to go back up by 2 centimeters, that may be all you need to do to feel like yourself again and like you're not feeling that any longer. Where it may not be as effective for actual stage of prolapse is when it gets a bit more advanced. And so if somebody has what we consider like stage 4 prolapse, where the vagina is coming almost all the way out, it's a little bit harder to reverse that necessarily with just pelvic floor physical therapy. However, they're really good at helping, again, with some of the modifications in lifestyle to help with prolapse. Pessaries, so these are, if prolapse is almost like an orthopedic injury where your options are, you hurt your knee, so you either do nothing or you do physical therapy or you put on like a knee brace. This is akin to that, but it's almost like a vaginal support brace. And so it's a great non-operative option. It is available for all women to try, and it's successful in about 75% of women. So there are certain factors with anatomy or prior surgeries that may come into play as far as whether or not a pessary will work. But the thing is, we have lots of different types of pessaries, different sizes, with the goal being that we want it to be comfortable to do the job. So it should be lifting everything up appropriately in the way that you're looking for it to work, and not falling out easily. So if it's comfortable and doing the right job, it's holding up the prolapse. You don't notice that it's there, and you're able to do all of your normal activities without having to deal with that sensation or feeling of a bulge or something coming down. In more long-term data, it looks like, typically speaking, about 50% of women continue to use pessaries long-term. So for women that want to try it out initially, sometimes it's just a temporizing measure where they're using it until they have enough time to recover from a surgery. And other times they want to try it out, and maybe for whatever reason, it's either too cumbersome or they don't like it. And I can talk about some of the reasons women may not like it. They decide to move on and do something different. It does have to be removed and cleaned periodically. And this is important because you can't just have it placed and that's it, and never address it again. By periodically, some women use it and take it out every day. Some women do it once a week. Some women, because of physical constraints, whether it is something that is more anatomic or what it might be, are not able to do it themselves. And in those situations, we will manage it for them. And so I have women come in anywhere between every 4 weeks to every 4 months, but nobody really goes beyond 3 to 4 months before taking it out and cleaning it. And that's just because the pessaries are made out of a silicone material that's very inert and very well tolerated, but it is a foreign body that sits in the vaginal area. And so it can rub over time. And if it rubs, it creates a little bit of a discharge. And in doing so, you run the risk, if you don't take it out and cleaning it, of getting little ulcerations or erosions in the vaginal skin. You don't have to be using vaginal estrogen to use a pessary. It's not mandatory, but oftentimes women that are using a little bit of vaginal estrogen do a little bit better with the pessary because it just thickens up the tissue a little bit so that you don't have such a risk of having it rub or cause little irritations. These are a bunch of different types of pessaries. I would say the most common ones we use are going to be this one here. This is called the ring with support. And it's sort of akin to almost like a diaphragm, although clearly with the holes in it, it wouldn't be a very successful diaphragm. But it basically just folds in and you're able to place it in the vagina. It sits so that it's kind of at an angle in order to hold up the bladder and hold up the top of the vagina or the uterus and cervix, depending on what's at the top of the vagina. It works really well for sort of moderate prolapse. We have found that sometimes it's not sufficient for the more advanced prolapse. So for more advanced prolapse, we may be more apt to use one of these types that stays a little bit better. So this is called a Gellhorn pessary right here. And it actually has this ring at the bottom is a little bit like suction. And so it can help it stay up, and it stays up a little bit better. And these all look like, I know, crazy contraptions, but they all are a little bit different. And again, finding a pessary is sort of like going to Nordstrom and finding some shoes, where you have to try on a few to figure out which one is perfect for you. But once you find one that you like, and again, about 75% of people can, it should be something where you don't even know that it's there and it's getting rid of the symptoms that you're having. To talk about non-conservative treatments. So far, we talked about expectant management, which is basically doing nothing but monitoring and then maybe making some lifestyle changes to help out. Physical therapy, pessaries, which are non-operative methods of holding up the prolapse. And then there are surgeries. So with surgeries, I tried to make it really, really basic because there are all kinds of nuances, and this, of all parts, are very dependent on degree of prolapse and sort of symptoms that are associated and desires. So reconstructive or obliterative are the two sort of initial defining categories. Reconstructive means putting it back where it belongs, essentially. And you can do that with or without a hysterectomy. You can do it on somebody that's already had a hysterectomy. It can be done transvaginally, which is the most minimally invasive because there are no incisions then on the abdomen. Or it can be done laparoscopically or abdominally. And more often than not, we do almost everything now laparoscopically or robotically, which is a version of laparoscopic, because it's more minimally invasive than if we had to make a big incision. Obliterative is a little bit different, and we'll talk about this at the end. Obliterative procedures are very, very successful, but we typically reserve these for women that have very advanced stage prolapse and maybe are not great surgical candidates from having like a general anesthetic or a long surgery, because these surgeries are very quick, can be done under a spinal type anesthetic, and they're very successful. The recurrence rate is really like less than 5% with them. But when we do them, and they're considered a very superficial surgery, when we do them, we essentially put everything back where it's going to be and we collapse down the vagina. So that when that happens, the vagina is then no longer available for vaginal intercourse. So reconstructive surgeries, which are a bit more common, obviously, than ablative, for transvaginal, and this picture is just happens to be in somebody where the uterus has been removed. So you're just looking at the vagina here, but these can be done at the same time as doing a hysterectomy, or you can do it with leaving the uterus in place, which is called a hysteropexy. Meaning lifting everything up, because that's the part that matters. The uterus it's not really the fault of the uterus in this, it's the fault of the ligaments. And so there's actually some newer data out to suggest that doing this and leaving the uterus in place is very effective. And so you may not need to remove the uterus at all, which used to be our old dogma of the uterus has to come out and we have to resuspend. That's not necessarily the case any longer. These that are done transvaginally for prolapse, not for urinary incontinence, but for prolapse, are done using suture only. So some of the sutures are permanent, some of them are semi-permanent, but essentially they are done using just sutures. They are minimally invasive, and they're the most minimally invasive surgeries we have. You don't end up with any incisions on your abdomen or anywhere else. It's just operated completely through the vagina. And long-term success rates, obviously this is a big range, somewhere between 65 to 85%. And the reason the range is so large is because the definition of success changes with every study that's done, whether it's purely based on anatomic data points, or it's based only on symptoms, or it's based on a combination of the two. And probably what's most relevant is a combination of the two, but it's hard to tease it out specifically, especially because all the surgeries are a little bit different. For repair of the wall, so this is just to kind of give an example of what it would be if it wasn't just the top of the vagina we were suspending, which it's important to note that almost always now, if the bladder is coming down, we also suspend the top part, because the two almost always go hand in hand. And if you just repair this one, and if this is coming down a little bit up top, it's going to pull our repair right back down again. So we almost always do a few sutures up at the top to anchor it to make sure that it doesn't come down. So this is just showing sort of a schematic of how it's done. But basically you make an incision in the vaginal wall, and then this is the underlying support tissue that gets plicated or reinforced back together with stitches. And then again, you close up the vaginal tissue again over it. Same idea for the back wall, exactly the same thing. So again, for when the rectum is pushing into the vagina, we repair this typically transvaginally as well. Same idea, where we make an incision in the skin, we reinforce the tissue underneath, and then we close the skin back up again. The sort of gold standard reconstructive surgery for prolapse for the top of the vagina coming down is called a sacral colpopexy. And it's more effective, and the reason it's more effective than just using, or more durable is a better word, it's more durable. And the reason it's more durable than using just stitches is because part of the reason that the prolapse occurred in the first place was that some of the ligaments and the support structures were not as strong. And so we bypass your own ligaments by using mesh. Now, does it have to be mesh? It almost always is, although there are some places in which they will use, similar to like what Dr. Morrisroe suggested, they'll use your own tissue. We don't have any really great long-term data on that at all. So by and large, when you think about this, it is done with mesh, and it's like placing a suspender on either side of the vagina. A really important defining point on this is that this is done transabdominally. We're not doing this transvaginally. So this is considered a sterile procedure because we're operating in a sterile environment, and we're not operating through the vagina, which may not mean a whole bunch other than that mesh complications are much higher when you're doing large pieces of mesh through the vagina. And the mesh complications with the sacral colpopexy are acceptably low. This procedure has been done for literally more than 60 years, and we've refined it over time. And now the material that we're using is very similar to it's actually the same material, essentially, that's what's being used for abdominal wall hernias. And while it does have a complication rate, the complication rate, if you leave the cervix in place and do not enter the vagina, in terms of mesh erosion, is somewhere around 3%. So it's very low. And the efficacy rate at 5 years is over 85%. For the obliterative procedure, and this is just for kind of a schematic to show what happens, it's really reserved for advanced stage prolapse in women who are not really candidates for large surgeries that maybe take a long time and who are also not sexually active. So that's a very important point. It's very minimally invasive. It's a quick surgery. It has a 95+% efficacy long-term. And you can use even like a spinal anesthetic. So you don't need to have a general anesthetic. And I think that's it. So I think all questions were going to be reserved for the end, but that's what I wanted to talk to you guys about today. It's very, very brief because prolapse is a very large subject, but hopefully I was able to give you some information that you found interesting. And thank you very much. I'll turn it back over to Jenny.
Thank you, Dr. Mellano. That was great. I thank you for the shout out for physical therapy being really beneficial for the symptoms of prolapse. And even with pessaries, if someone is using pessary to kind of help with those really acute symptoms, and then using physical therapy to strengthen to then hopefully get off of the pessary long-term, that is really helpful too. So that was some great information about prolapse. Thank you. So our last speaker is Dr. Reza Askari. Dr. Askari is a native to our beautiful South Bay. He went to the University of California, Santa Barbara and studied medicine at the Saba University before completing his residency training in OB-GYN at the Lincoln Medical Center in the Bronx, New York. He also did 4 years of residency in minimally invasive, at 4 years of residency, he developed his interest in minimally invasive surgery and then spent his fellowship training in minimally invasive gynecologic surgery at the University of Buffalo, State University of New York. He received his board certification in 2013. Dr. Askari has always had a longstanding interest in urological issues and pelvic floor disorders because his own father is a longtime South Bay urologist, and he further developed in the field of pelvic floor disorders during his time in fellowship. He specializes in urogynecology and minimally invasive surgery and joined Providence in 2015. Dr. Askari is devoted to providing a full range of advanced, minimally invasive, and robotic and urogyn surgical services. And besides being active in our local medical community, he is happily married and a devoted father to his 3-year-old and 4-year-old daughter and son. And by the way, I want you all to know that the Dodgers are winning if you are paying attention to the game on your other screens. All right, everyone, welcome Dr. Askari.
Hi guys, thanks. I'll shorten my bio. That was kind of embarrassing, but thanks guys for being here today. Thank you, everybody. Let me share my screen. 2 great talks. Wow, that was very impressive. So as I find my screen here, let me come back down. Is this looking okay, Jenny? Does this look okay?
I can see your speaker notes.
Okay, you can see my, let me just come back here. I had this all set up too.
For display settings, I think you can switch settings if you've got 2 screens up.
Okay, let's do this. All right. Display settings, let me, how's this? Is that better?
Didn't change anything.
It didn't, okay. Sorry, guys. My screen, let me find. How's this? Let's do this. How's that look?
Now we have a little more. We can see a little more email on the right side of your screen.
Okay.
But we love technology. Sometimes it's our friend, sometimes it's our challenge.
So, you know, this is funny because I had this up earlier And let's see. How is this?
All I see is launch meeting Zoom.
Oh, okay. Well, looks like it's not working for me, guys.
Can you go back to the way you did it the very first time?
So I am, yeah. Let me stop the share here. Just real quick. Okay, let's go.
There you go. Perfect. You got
This
it.
is good. Okay, sorry for that delay, everyone. So my name is Reza Askari. I work for Providence. Thanks for joining us. Sorry for that delay. So I'm just going to briefly talk about uterine fibroids in your midlife and beyond. Essentially, what can cause stress incontinence and those pelvic pressures? Fibroids. Those pressures in your pelvis, fibroids. So first question is, what are fibroids? We have a picture here. They can occur, that's your uterus. They can occur in many different locations. And I won't take up too much of your time tonight. So fibroids they're non-cancerous tumors generally that grow along the walls of the uterus. They're primarily made of smooth muscle cells. So they are muscle cells and they can dramatically range in size. Some fibroids are so small where others can be big. They can be as big as a grapefruit. They can be not as big as a watermelon, big as a grapefruit, even larger. On average, these tumors, and when I say tumor, remember, they're mostly benign. They range from the size of a large marble to the size of a grapefruit baseball. And here's a picture. What I have here is, these are real life fibroids from a surgery. Many times there's multiple fibroids that we identify, and there also can be solitary fibroids, and they can range in size. Here's another picture of the uterus right here with multiple fibroids all along it. We call these serosal. They're on the outside of the uterus. Looks like there could be one inside the muscle here too. So let's talk about, like I said, they're benign, but let's just talk about our concern for cancer. The reason why I bring up fibroids today is because they can cause the symptoms that Dr. Mellano and Dr. Morrisroe so greatly explained. But fibroids are benign by definition. Although you can get something called a leiomyosarcoma, the numbers can range from 1 to 1,000 smooth muscle tumors. Sometimes we say 1 to 360, depends on where you're getting the literature from. But this type of cancer is rare and they do not arise from the benign fibroids. Therefore, if the fibroid's benign, another fibroid is not going to grow back as cancer. I have not seen one in the time of my practice. And your chances of developing a cancerous growth do not increase because you have uterine fibroids, nor does having them increase your chance of getting other uterine cancers, such as endometrial. So the symptoms, many of you may have known of someone with these symptoms and they've come back to tell you they've had fibroids, but many people experience no symptoms. That could be you, that could be your friends. But for 25% of patients, some symptoms will occur. A lot of times it could be abdominal pressure, pelvic pressure. It can feel like fullness in your pelvis, maybe bloating in your pelvis or stomach. You could get fuller earlier. A lot of times the larger fibroids, the leiomyomas, can enlarge the lower stomach area, so you can sense that you're gaining weight and your stomach is kind of outpouching. Sometimes they give the false appearance of pregnancy. They can impact your menstrual cycle. That's commonly what the patients will come in and see me for, is they can increase the way you're bleeding. It could be more spotting, breakthrough bleeding. It could be mild to severe cramping. It could just be a change in the structure and the style of your menstrual cycle. A lot of times people will find the issue as their bleeding is heavier, when they start passing blood clots, they start becoming more fatigued. And again, as I mentioned earlier, they can be longer periods or spotting or bleeding in between. So what else? Back pain. It's not just from lifting something, it could be from a fibroid. Also, as we're speaking about bladder and female pelvic floor issues, they can press against the bladder and you can be provoked to have more frequent urination or loss of urine without control. So the prevalence in this talk I'm sure many people in this talk do have fibroids. And it's estimated by age 50, as many as 70 to 80% of our patients will have them. Although the causes remain unknown, there's a couple different factors that indicate a higher risk of occurrence. One can be age, another can be family history. Family history is that if a family member of yours, such as your mother, has it, then you are 3 times as likely or just more likely to have the fibroids. Also of note, menopause, fibroids tend to shrink, but I put that's not always the case. They can shrink, but sometimes they can get a little heavier, they can get calcified. But the good thing is in menopause, if you have bleeding issues, and typically if you have a fibroid, the bleeding will stop and you don't have to do anything for the fibroids. Diet is very big. I really believe that diet plays an important role in our development of health. And some foods definitely do encourage fibroids, while others seem to discourage them. Can you guess which one? Like, I'm a big meat eater, but don't eat meat, don't eat red meat. And it's a no-no. I find that patients that do eat these type of foods that have a lot of free radicals, and then fast food, red meat, just unhealthy diets, they tend to promote more vascular and larger fibroid structures. Now, what can help? I know you guessed it. Yes, foods that are lower are plenty of green vegetables. It also notes that dairy products do help, but dairy, you know, it's good, but please also do that in moderation. But also studies are showing vitamin D, iron, and vitamin A, the micronutrients. And the studies are linking that, and the reason why I bring this up, in California, a lot of us are low in vitamin D, even though it's a sunny state, that low vitamin D levels do contribute to fibroids. So if one note you can take from my talk, take vitamin D daily. That'll lower your risk. So health complications, as you can imagine, for bleeding, you can get anemia. If it's blocking areas in the uterus, it can cause infertility. Chronic pelvic pain, it's not just endometriosis, it can be fibroids, stress incontinence, urinary urge and frequency, overactive bladder, and constipation. So when should you see a doctor? I suggest anytime you have a change in your cycle or any of your experiences that you're not usually used to, like if it's heavier periods or your periods become more painful, or you have an issue with your bladder, please see your physician. Typically, the good physician to see is directly seeing your OBGYN, but you can definitely see your primary care. And, you know, if you notice again that the length of your period is changing for more than 3 cycles, or if you're displaying persistent signs of heaviness or pain, definitely come see one of us. Fibroid treatment, it's as simple as a warm heating pad or taking Tylenol or ibuprofen or naproxen. It's that simple. If that doesn't seem to help, we can place you on birth control. For those of you that tend to have bleeding issues, we can do standard birth control. We typically start with a low dose counterpart that can help alleviate the symptoms. There can be injected birth control. Not a big fan of Depo-Provera, but we can do that. IUDs really work well. So the progesterone releasing IUDs, and they're tailored to function very well for you. So you can avoid any more aggressive managements. So as we talk about management, I brought this up. So now we're getting toward more of the surgical side. This is a non-surgical alternative, uterine artery embolization. The reason why I bring this up first is this therapy is offered. Typically, what it does is it seals off blood vessels. Don't recommend it if you want to get pregnant. It can shrink your fibroid, but typically we use them for patients that are really not surgical candidates. It's not a first line, or I'd say second line approach. It's more third line, but I just wanted you to know that, and our radiologists offer them here at our hospital. And this is a successful treatment, but as I said, it's for the patient that really wants to, it's not eligible for anesthesia or doing anything in the operating room, and it is an alternative. Now, and we're getting toward the end of my talk, the fibroid treatments are really, it's surgery. It can come down to 3 options. One is endometrial ablation. The other one's a myomectomy, which is taking out the fibroids. And the third one's a hysterectomy. Endometrial ablation. Typically, I'm using this only for patients that bleed. So what it does is we basically, what you have here is you have the inside of the uterus. So we enter between the legs through the vaginal vault, through the cervix into the uterus. And we use a very thin, what we say, very thin millimeter device with a camera where we go inside and we look at your endometrial lining and we jet off very hot water. And essentially it just destroys that lining of the uterus that causes you to bleed, which is the endometrium. I'm typically doing it more so for patients that bleed, but we can do it with patients with fibroids that have the bleeding, depending on their location. And what that can do is that just allows no more tissue to be available to bleed. It's a great procedure because it's outpatient. Patients can go back to work the next day or have off during the weekend. And it has a high success rate, anywhere from 65 to 85%, depending on when you do it, at what stage of life you do it. And we typically do it when you're between the ages of 30s up to 50. Myomectomy. Now, myomectomy is for those who wish to become pregnant. And one thing about ablation, I apologize, I skipped over that. If you do want to get pregnant, we do not do ablation. Myomectomy is when we take out the fibroid, and we offer that for patients that desire pregnancy, or when I practiced in Buffalo when I was in my fellowship, it was for people that want to do uterine preservation. They want to preserve their uterus. The surgery can be done multiple ways. It can be done abdominally. It can also be done robotically. It is a major surgery. Typically, we allow the patients, I typically have been doing them more abdominally, allowing it to be through a single incision. The patient will stay for about a day or two, but robotically can do them. And I forgot to say, if the fibroid is located within the cavity, we can go between the legs and use a hysteroscope, which basically shaves off or removes the uterus. Fibroids can develop later on, depending on when you do it, but it's a procedure that has great success. In case you're wondering, this is the uterus, these are the ovaries, these are your tubes, and this is someone removing a fibroid. Last but not least, and this is my last slide, this is hysterectomy. So this is a permanent treatment for the uterine fibroids. That is the second most major surgery done in the country. About 200,000 hysterectomies are performed every year in the US for treatment of leiomyoma. And hysterectomy involves removal of part of all the uterus, including the cervix generally, sometimes the ovaries, depending on your stage of life, along with the fallopian tubes, which we do all the time now, which decreases your risk of ovarian cancer. It is a major surgery, but the health risks are amongst the lowest of all major surgeries. And recovery time for hysterectomy, if you do it through the abdomen, it can be about 4 to 6 weeks. We're typically doing it robotically, and that's same day surgery where you go home, but still the recovery is still 6 weeks. Now, you can do it vaginally, which is a great minimally invasive option. You could do it robotically or laparoscopically, which is the same thing. Robotics just an adjuvant to laparoscopic. And you can also do abdominal depending on the size. If they're very large, typically that's our last resort, and that's what we do. I just kind of summarized fibroids in a bunch. I didn't want to show too much. I appreciate your time, and I thank you very much.
Oh. Thank you, Dr. Askari, for really enlightening us about all of our options to manage fibroids. So we've been getting some Q&A into our little chat box here. I know we had answered a few of these during our talk by typing in the answers. I think everybody can see those as well. Before we begin the Q&A, we actually have a few questions for you guys. If you can please answer, you're going to see a poll coming up on your screen with 4 votes. There are 4 questions here that you can vote on. So we would love your honest feedback on what you got out of the presentation today. So now we're going to begin the Q&A and keep putting some questions into that Q&A box if you would like us to talk about those. I know we're running over a little bit. We had so much information to share, so we will get through the new questions that are in the chat right now. So for Dr. Mellano, there's a question about, is a prolapse diagnosed during a pelvic exam, and how is it diagnosed exactly?
Yes. So typically during a pelvic exam, and it can be diagnosed because somebody's coming in specifically for that, or it might be something that is noted by the practitioner during the exam, and they will then evaluate it a little bit further. It's not necessarily diagnosed on just like a straight pap smear. It is something that is a little bit more of a dynamic exam. So if it's obvious on a pap smear, the practitioner may bring it up. But sometimes it's something where we need somebody to actually do some maneuvers to bear down so that we can see how far down it comes. So yes, absolutely diagnosed on a pelvic exam.
Okay, can I show just a little? This is my vulva puppet that I use to teach physical therapists. And if we are looking here at the labia, and as somebody was to bear down or cough, which is what Dr. Mellano is talking about when she's talking about a physical exam, we can have some tissue bulging out from the vaginal opening. And we are grading prolapses by how far they are either inside or outside the hymen right at the vaginal opening. So just in case you want a little visual there, I thought I'd throw that in. All right, the next question is for Dr. Askari. Do fibroid tumors in postmenopausal women complicate treatment? Oh, that probably could be treatment for prolapse as well. So whoever wants to weigh in on that would be great.
Depends. I mean, treatment for, if it's regards to pelvic organ prolapse or stress incontinence, it depends on the size of the fibroid, but typically, no, I think we can treat that individually. Erin, Shelby, do you guys have anything on that?
What was the question again?
Explain the question again.
Do fibroids in postmenopausal females complicate any treatments? Am I correct, Jenny?
Yes.
Yeah.
In terms of incontinence, not generally, unless we're talking about really large fibroids. As you probably mentioned, I mean, fibroids tend to shrink postmenopausally and cause less issues with age, short of a situation where there was a really large fibroid putting pressure, on the bladder. Generally speaking, I do not equate it with urinary incontinence issues.
I would second that. I think that maybe the way it would apply maybe to a prolapse surgery is if you were trying to do maybe like a vaginal hysterectomy, and in doing so you had a very large fibroid. As long as there's adequate descent of the uterus, you could still accomplish the surgery. So that would be the only complicating factor of a surgical repair. But agreed, after menopause, typically speaking, fibroids are smaller and less problematic than they were before menopause.
Great. Next question, can you have a sacrocolpoplexy after a failed mesh surgery?
I think that's a little bit of a complicated question. Technically speaking, sure. And in fact, there was a provider that I used to work with who would always take out mesh, but he would do the colpoplexies then using fascia instead. So yes, you can, but I think there's also a question as to why did the first surgery fail and what was the mesh complication? Because it does make a little bit of a difference as to whether or not we would attempt a secondary mesh procedure.
Great. So patients like that with that type of story would need to go in and get an individual exam to be able to know if that is a good one. There's a question, is it okay to do squatting exercises if there is a prolapse? Shall I take that one? Yeah. So anytime you do any type of activity where you are increasing pressure in your belly, so thinking like from your diaphragm down to your pelvic floor, and that could be coughing, sneezing, lifting, squatting, grabbing a 30-pound bag of dog food, holding your toddlers, you have to be able to manage that pressure, absorb that pressure, and not kind of blow it downward towards your pelvic floor. So with squatting, it's absolutely fine to do squatting as long as you are accepting load really nicely. So say you're squatting holding weights or those types of things. So one of the easy tricks to start to do that is to exhale during the hardest part of the squat, because holding your breath would bear down to that tissue. And another trick is to put a tampon in, maybe not all the way. And if you're squatting and you can feel it pushing out, then you're bearing down too much. So yes, safe. Next question, for both treatments for incontinence and prolapse, are there any special considerations for patients who had uterine cancer with chemo and pelvic radiation? Post these treatments, what is a reasonable time to seek consultation?
I can start with that one. That's a really excellent question, and it brings to light a couple of things that complicate incontinence treatment. There's absolutely treatments we can do to make incontinence better after complicated pelvic reconstructive surgeries or radiation, but the tissue is less healthy. It does not respond generally as successfully and well to the classic treatments. It is actually a great utilization for medication or the Bulkamid transurethral bulking agent injection I kind of showed a video on and talked about today. We do try to avoid the use of mesh or permanent material in the pelvis after radiation. Radiated tissue tends to be thin and poorly vascularized and doesn't heal very well. So that's where we really try to focus on conservative treatment therapies, non-foreign material mesh-related surgeries, things like physical therapy, medication, injection therapy. 6 months to a year, 6 months really after radiation is a completely reasonable time to start with those therapies like injections. Medicine and therapy you can do right away. So you should not wait more than a few months to discuss with your doctor treatment options after complicated surgery or radiation. But it's just that some of the surgical options we try to avoid in patients that have undergone that.
Great. And Dr. Morrisroe, while you are chatting, you see a lot of advertisements for an injection called the O shot. And you had talked about a bulking agent for the urethra that could be collagen, it could be PRP. Could you tell us the difference of those two options?
Yeah, they're different, but share some of the same qualities. I don't do the platelet-rich plasma injections. That's a treatment that you can use in different parts of the body, where you take someone's own blood and spin it down and kind of take away some of the plasma and re-inject it to different parts of the body to help regrow tissue, make tissue healthier. And it can have some degree of a filler or bulking effect also. So it's used more commonly to be injected vaginally around the clitoris or the G-spot, or vaginally for heightened sexual sensation, lubrication, those kinds of things. But you can plump it up and inject it kind of under the bladder neck area to try to help with some stress incontinence. I do not know of any good recent studies that show, efficacy of significance, or, really head-to-head studies. My strong suspicion is that something more tailored specifically to stress incontinence, like the Bulkamid, is probably got definitely a higher success rate. But I think that's a really interesting and great option for the woman who has multiple things she's trying to achieve. If a woman's only goal was stress incontinence treatment, I would assume the Bulkamid or something which is more directed towards that would have a higher success rate. But if you've got some lack of sensation, some dryness, and some mild stress incontinence, I think that could be a great option.
Great, thank you for that. I have an 8.2 centimeter fibroid. I was advised to get a hysterectomy. Are there other options for me if I do not want a hysterectomy?
A couple thoughts come to mind is, what would be your age? Because if you're nearing menopause and you don't have really any severe symptoms, you can just wait. The other options are doing birth control or an IUD. And the other options are, you could sometimes do, depot loop-on would shrink it, but it would come back. It really depends on your age, what your presentation signs are with, because each patient, I think the whole bulk of our talk here is really in our field. Each patient has to be evaluated individually. Even though you have fibroid, stress incontinence, or prolapse, each person presents so differently, even though it's such a big general subject. So I'd have to know more about you, but there's always definitely different options. There's as long as you're not, your bleeding is controlled, your pain is controlled, you don't have to do anything for fibroids. And that's really what it comes down to.
So Dr. Askari, when we're talking about like an 8.2 centimeter fibroid, is that in the big fibroid? Is that in the small fibroid? Like, where would you?
So I'm just sure it's big, but if you're, as much surgery, I think, as we all do, we always practice conservative care. And I've seen doctors, you come in, it's 8 centimeter fibers, like, I want to take it out, right? It's 8 centimeter. But you have to ask the patient, is it bothering them? I mean, are they bleeding? Are they severely anemic? I mean, because remember, I said most fibers are benign, correct? So I'm not concerned for cancer. Doesn't need to get, in my opinion, doesn't have to get biopsied unless it's a fast growing fibroid or there's multiples. And the 8.2 centimeter fiber, she doesn't have significant bleeding, or I'm able to control her bleeding with hormones or an IUD. If I'm able to control her pain, her urination symptoms, her bowel symptoms are fine, you could watch it. Now, granted, if she's 30 something years old, I think other doctors would agree with me, it's going to grow and sometimes it's going to probably have to come out. But if you're 48, 49, and we know menopause is around the corner, you could be quite conservative about it. A lot of times, when you come in and see us, and sorry to keep belaboring this point, you kind of just want to know what your options are. Not for us to necessarily just give you a solution, know what your options are, kind of let that resonate, and then maybe come back and continue the conversation. But with fibroids, it's something that really just depends on how much it bothers you, where you are at the stage of life, and just knowing what you can or can't do.
Great. And kind of the wrapping up around fibroids, since that's kind of the hot topic here at the end. How can you tell if a fibroid is cancerous, and can they affect fertility and make pregnancy dangerous for the fetus?
Well, typically and Erin, I think, if you don't mind chiming in, if it's a very fast growing fibroid, rarely if radiology maybe makes a comment on it, or if there are multiples of fibroids, we have a concern. In terms of infertility or fertility for the fetus, typically, I have not come across where you've seen a fibroid that's a leiomyosarcoma and it has a fertility issue. I've seen it more where it's a fibroid that causes a blockage where you can't have pregnancy, and that's the concern. Erin, I don't know if you have any input on that as a.
No, I mean, I agree with you. A leiomyosarcoma or a cancer of a fibroid is very incredibly rare. And the hard thing with diagnosis is that things like what we normally rely on, like biopsies of the inside lining of the uterus, which we can do in clinic, don't always diagnose it. Oftentimes on radiology imaging, it looks different, which sounds funny to say that, but because fibroids are kind of funny looking when you think about it. But it looks like the borders are maybe not super distinct. And so that might prompt then an MRI, and if it's growing quickly, and then sometimes we'll check markers, which are not totally accurate, but it's really uncommon. So likely things being likely, the fibroids, especially if there's several and they're not growing rapidly, they're benign. If it's one dominant fibroid that's growing quickly, maybe has not clear borders, that would be something that might be a little bit more concerning. And I agree, a fibroid cancer in a pregnancy, I mean, I think that's probably case reportable. It's not something that is very common at all. But fibroids, the way in which they impact pregnancy, similar to what Dr. Askari said, is that it's the same thing. It just has to do with either delivery being altered because the fibroid is blocking the ability for the baby to come out vaginally. Sometimes if there is a C-section, if there's a lot of fibroids in the way, that can make it challenging for, luckily I don't do those anymore. I'm sure Dr. Askari can answer to this, but can make it a lot more challenging sometimes because the fibroids can bleed a lot. And occasionally if a fibroid gets pretty big in pregnancy because they are hormone driven, if they get pretty big, they can outgrow the blood supply. And when that happens, they can start to release things that can cause a lot of discomfort and pain, and sometimes even like preterm contractions and preterm labor. But those are not, I mean, many women have fibroids and are absolutely fine in pregnancy. Those are sort of if there was to be a risk, what could the risk be? Again, most of the time it's absolutely fine.
Excellent. Well, thank you everyone for joining us tonight to chat about all things pelvic health. We are thrilled that you came with us. Everyone who had registered for the talk will be receiving a recording of the talk via email in the next few days. This also will be posted up on the Providence Facebook page. So if you want to share it or listen there as well, you sure can do that. The Facebook page is Little Company of Mary South Bay. And for any additional information or to schedule a physician appointment, you can call the Providence Patient Engagement Center. The phone number is right there in the chat. 888-HEALING would be where you would call. So thank you again. I hope you learned some really valuable information that is able to impact your life, your quality of life, and have a great rest of your evening. Thank you.